Good morning, everyone. Myself, Dr. Ravi Kesri. Today, I am discussing about the fibula bone. This is the fibula bone. For site determination, the see my separate video. The fibula bone, it is the lateral bone of the leg and it is homologous with the ulna of the upper limb. It does not participate in weight transmission and it has no contribution in knee joint formation. It is long bone, slender bone and pen like, having the upper end, the lower end and the shaft. Now the features of the fibula. The fibula has an upper end, the shaft and the lower end. The upper end or the head. It is slightly expanded in all its direction. The superior surface bears a circular articular facet which articulates with the lateral condyle of the tibia. The apex of the head or styloid process, this is the styloid process, projects upward from its posterolateral aspect. The constriction immediately below the head, is known as the neck of the fibula. The shaft has the three border and the three surfaces. The three borders are the anterior border. This is the anterior border. Second is the medial border. This is the medial border, or also called the interosseous border, and third is the posterior border. And the surfaces are the medial surface, the lateral surface and the posterior surface The anterior border, it begins just below the anterior aspect of the head. It just begins the anterior aspect of the head. This is the anterior border, and begins just below the anterior aspect of the head, and at its lower end it divides to enclose an elongated triangular area. This is the elongated triangular area which is continuous with the lateral surface of the lateral malleolus. This is the lower end. The posterior border, this is the posterior border, and this is the rounded. Its upper end lies in line with the styloid process. This is the styloid process. Below the border is continuous with the medial margin of the groove on the back of the lateral malleolus. This is the groove present on the back of the lateral malleolus. Second is the interosseous border, and this interosseous border, it is also called the medial border. It lies just medial to the anterior border. This is the anterior border and this is the medial border or interosseous border, and it lies just medial to the anterior border. It terminates below at the upper end of a roughened area. It terminates below at the upper end of the roughened area. This is the roughened area above the talar aspects of the lateral malleolus. In its upper two-third, the interosseous border lies very close to the anterior border, in its upper two-third. Now the surfaces. First is the medial surface, the lateral surface and the posterior surface. Medial surface, it lies between the anterior border and the interosseous border. This is the medial surface. In its upper two-third, it is very close, measuring 1 millimeter or less. The lateral surface, it lies between the anterior border, this is the anterior border, and the posterior border, this is the posterior border. The posterior surface, it is the largest of all the three surfaces, and it lies between the interosseous border, this is the interosseous or the medial border, and the posterior border, and the posterior border. In its upper two-thirds, this posterior surface is divided into the two parts by a vertical ridge. This is the vertical ridge called the medial crest. This is the vertical ridge or the medial crest. This is the vertical ridge or the medial crest, and this is the posterior border. This is the posterior border. This is the medial crest. The lower end, this is the lower end or the lateral malleolus. The tip of the lateral malleolus, this is the tip of the lateral malleolus, is 0.5 centimeter lower than that of the medial malleolus, and its anterior surface is 1.5 centimeter posterior to that of the medial malleolus, and it has following four surfaces: the anterior surface, the posterior surface, the lateral surface, and the medial surface. The anterior surface, it is rough and rounded. The posterior surface, it is marked by a groove. This is the groove. This is the groove. And the lateral surface, this is the lateral surface. It is subcutaneous. And the medial surface, this is the medial surface, bears a triangular articular facet for the talus anteriorly, and the malleolar fossa, this is the malleolar fossa posteriorly. Now the attachment and relation of the fibula. From the medial surface of the shaft, this is the medial surface of the shaft, which is present between the anterior and interosseous border. The three muscles, the extensor digitorum longus, the extensor hallucis longus, and peroneus tertius are attached. Now the extensor digitorum longus origin from the whole of the upper 1/4 and the anterior half of the middle 2/4. It is divided into the upper 1/4, the middle 2/4, and the lower 1/4. The origin of the extensor digitorum longus from the whole of the upper 1/4 and the anterior half of the middle 2/4. Extensor hallucis longus originate from the posterior half of the middle 2/4, and peroneus tertius from the lower 1/4. The part of the posterior surface between the medial crest and the interosseous border, this is the medial crest and this is the interosseous border, the grouped part, and gives origin to the muscles that is called the tibialis posterior muscles. Tibialis posterior muscle. The part of the posterior surface between the medial crest, this is the medial crest, and the posterior border, this is the posterior border, gives origin to the soleus from the upper 1/4 and flexor hallucis longus from its lower 3/4. The posterior surface between the medial crest and the posterior border gives origin to the soleus from its upper 1/4 and the flexor hallucis longus from its lower 3/4. The lateral surface of the shafts gives origin to the, this is the lateral surface, and the lateral surface of the shafts gives origin to the peroneus longus from its upper 1/3 and the posterior half of the middle 1/3, and the peroneus brevis from the anterior half of the middle 1/3 and whole of the lower 1/3. Common peroneal nerve terminates in relation to the neck of the fibula. Now the head of the fibula, this is the head of the fibula, and it receives the insertion of the very important muscle biceps femoris on its anterolateral slope of the apex, and this insertion, it is C-shaped. The fibular collateral ligament of the knee joint, it is attached within the C-shaped area. Capsular ligament of the superior tibiofibular joint is attached around the articular facet. The articular facet. Here is the articular facet, and the capsular ligament of the superior tibiofibular joint is attached around the articular facet. The anterior border of the fibula gives attachment to the anterior intramuscular septum of the leg and superior extensor retinaculum to the lower part of the anterior margin of the triangular area, the lower part of the anterior margin of the triangular area, and superior peroneal retinaculum to the lower part of the posterior margin of the triangular area, the superior peroneal retinaculum and the superior extensor retinaculum. Now the posterior border, it gives attachment to the posterior border, it gives attachment to the posterior intermuscular septum, and interosseous border gives attachment to the interosseous membrane. The triangular area above the medial surface of the lateral malleolus and gives attachment to the interosseous tibiofibular ligament in the middle, the anterior tibiofibular ligament anteriorly, and the posterior tibiofibular ligament posteriorly. These are the attachment around the triangular area above the medial surface of the lateral malleolus. Attachment on the lateral malleolus, the anterior tibiofibular ligament to the anterior and posterior surface of the lateral malleolus, the inferior transverse tibiofibular ligament above, and the posterior talofibular ligament below to the malleolar fossa, The capsule of the ankle joint along the edges of the malleolar articular surface. The capsule of the ankle joint is attached, and the slight notch on the lower border gives attachment to the slight notch on the lower border. This is the slight notch present on the lower border. It gives attachment to the calcaneofibular ligament. The groove on the posterior surface of the malleolus, this is the groove on the posterior surface of the malleolus and lodges the tendon of the peroneus brevis and longus. Now the blood supply of the fibula. The peroneal artery, it gives off the nutrient artery for the fibula which enters the bone on its posterior surface. Now the ossification of the fibula. Fibula disobeys the laws of ossification which depicts that the secondary center which appears first fuses last. In lower end of the fibula, the center appears first and also fuses first. What is the region of the ossification? The upper end is a traction epiphysis and the lower end is the pressure epiphysis. So the center of ossification appears first in the lower end as per law which depicts when a long bone passes two types of epiphysis, that is the pressure and traction epiphysis, and the ossification center for pressure epiphysis appears earlier than the traction epiphysis. Since the direction of the nutrient foramen is downward, the upper end is growing in and it unites with the diaphysis, the late. Now some clinical aspects associated with the fibula. First is the common peroneal nerve. It is related with the neck of the fibula laterally, and in Hansen's disease it becomes thickened and nodular. And for the diagnosis of the disease, it can be palpated at this place. In fracture of the neck of the fibula, the common peroneal nerve may get injured, resulting in foot drop. The fibula is the bone of the choice for bone grafting, as partial removal of the fibula does not affect the locomotion. In first stage of the Pott's fracture, the lower end of the fibula is fractured badly. This is all about the fibula bone. Thank you.